work on it. So please.
Yeah, well, the second symposium that I was invited for was "What are you doing differently?" And for more than 2 years now, we've been using the light adjustable lens from RxSight. Now, I do consult for that company. So this has actually kind of solved so many problems. And what does it help us with? Well, we are getting more like LASIK-like outcomes. We don't have the risks of diffractive halos. It increases the patient confidence that you're going to hit the target and satisfy people. Patients really better understand what you're doing because there's a separate event from the surgery where they see their uncorrected vision improve, and that gets them very excited. So this is a technology, it's a 3-piece silicone lens that allows us to realign these molecules in a way that it actually changes the shape and the prescription of the lens very exactly. So this was launched in the US in 2019. We were the first in Northern California. And it's able to not only change the sphere, but also the cylinder. So don't be misled by the fact that it didn't take off in Europe. They did not have a toric correction at that time. So we can correct up to 3 diopters of astigmatism. If you were to lease the device, it ends up being about 2 cases a month. The lens itself is about $1,000 in US dollars. So you do standard phaco, but just you don't have to do any other aberrometry or toric alignment because you're going to wait to refract the eye and do the adjustment post-operatively in the office using this light delivery device. It's kind of like doing a YAG laser. There's an aiming light, it's painless, and it's about 2 minutes, a minute and a half or 2 minutes. So this is on the lower left, let me see if I can get that. This is showing how accurate the adjustment is. This is a lens in vitro, and you can see putting the ASCRS logo on it. So you don't see this adjustment. You don't really know what you've done, but this is just to show how accurate this whole system is. What really changed last year is a new enhancement where you now don't have a risk of accidental UV changing of the lens before lock-in. So since I started using this last July, I no longer have patients wear UV goggles, and that's been really nice for them. So this question of do we really need adjustable lenses, because gosh, we have so many great IOLs, new formulas, femto, Aura, but remember they all improve our average. They don't eliminate the standard deviation. You heard that nice talk from Doug about the outcomes. I like this study because this is 100 different clinics in Europe. This is a registry, so it's a real life study. And 27% of the eyes did not fall within a half diopter. That means they missed a 1 diopter, plus or minus 0.5, a 1 diopter landing zone in real life. So we know the reasons, as Doug said, you have these 3 factors. And he also talked about some of the tricky eyes that we have to deal with. And to that, I'll add people that have been wearing hard contacts for a long time, and you know their cornea is going to change post-operatively, other eyes where we get bad measurements. What about astigmatism? Don't we do pretty well? Well, we have problems, as we know, predicting posterior corneal astigmatism. You have irregular corneas like the keratoconus he talked about. Astigmatic keratotomy regresses. Toric IOLs at least have some risk of rotation. So like all of you, I love trifocals as a multifocal IOL. And for the perfect patient who hates glasses and is willing to take trade-offs, has perfect anatomy and a personality and expectations that I'm confident on meeting, I'll do it. But this leaves a lot of people who I'm not so confident about: large pupils, post-refractive, imperfect corneas. Refractive lens exchange is a problem because these people are dealing with good quality of vision to begin with. And then there's the expectations, the myope who, no matter what you do, they expect to read as well as they're used to. People doing contact lens monovision, and people that are demanding or perfectionist and very indecisive. So for those patients, the light adjustable lens using a mini mono strategy is a perfect complement because we are prioritizing quality of vision, for that RLE patient or the perfectionist. Obviously, if the patient already loves their contact lens monovision, and it helps, multifocals prioritize distant vision. And we have a lot of myopes. They're willing to wear distance glasses. They don't want to lose their near. And with the refractive change for the LAL, if they're not myopic enough, we can move it a little closer. I mentioned RLE. This is my favorite thing now. When we do this monovision, we know already how well this works with our monofocals because there's no side effects and good contrast, and we can fix everything with glasses. It's always been popular. But the challenges are, you better get one eye emmetropic. How do we know how much each individual will either want or tolerate in terms of myopia in the second eye? Hard to reverse it. And patients are often scared because either A, they don't understand it, they're anxious about they can tolerate it, or some hard contact lens wearers have not worn reading glasses for 40 years ever, and they expect me to achieve the same thing with cataract surgery. Think about why we are successful with contact lens mini monovision. Well, you get emmetropia, and you can change it, and you don't have to explain it to people. You just do it, and if they want more or want less, you change the lens. So this is what's neat. Now, it really also lets the patient change their mind from what they think they want preoperatively. So it lets them select the distance eye. We can vary the amount of myopia in the second eye. So we like it because all the counseling is done postoperatively, where my optometrist does this. We can show them what it's like to move the focus closer, and the patient's less anxious. And again, we have always maximized quality of vision. If a patient says they want to see in the distance, well, many of them prefer -0.5 to Plano. And if a patient says, I really want to read without glasses, well, many of them prefer -1.5 versus -2.5. There's no way to know that unless you could change this afterwards. And when we correct the astigmatism, the patient understands the value of what we just did. So this lets us demonstrate this and achieve what is basically premium monovision with high satisfaction, just like contact, because you can adjust it and you can reverse it. Low risk in terms of quality. Now, the next thing that will come, and this has already been in trials in Europe, is a little EDOF that you can adjust to one eye through an undilated pupil. Think of it like putting a custom Vivity segment in one pupil. And of course, we can also try miotics to increase depth of focus. And along the lines of what Steve was saying, we're doing these close sequentially. For my bilateral patients, I do almost all of them, more than 90% bilateral same day, because the main advantage, I think, for staged surgery isn't really risk reduction in terms of endophthalmitis. It's that the patient can try something out and change their mind. How many times do they want to see in the distance and then realize they can't see up close? Well, you would make the second eye closer. We have patients that have a multifocal. They don't want it after they see the halos in their second eye. But with the LAL, we don't have to worry about that. So we've been doing them simultaneously. So here, this was some data when we had done 109 patients. I'm up to about 150 patients now that I've done immediately sequential bilateral, because there's really no advantage to doing them staged. So a little bit of a hats off to Steve's talk and to Doug's talk. And for us, this has been an exciting technology.
I think you